threatening us all, or somehow which is responsible for that we are doing this format today, which is not bad because you can take the whole world into one room, and you can also share your research among all people. So yeah, you see that as Ruth already said, we are MOCOS International Research Group. I'm very happy that Till Krüger is today here, who is the founder of MOCOS. I will talk about this in some seconds. And I maybe can talk a bit about how do I got to this group and how I started with this project particularly. So I'm actually doing epidemiology for something like 4 or 5 years. And I'm more interested into dengue studies, and they're especially about system theory, system theoretical approaches, and stability and optimal control. And then I was in Philippines in middle of February to start of March. I flew back at the 8th of March. So you didn't see too much of COVID that time in Philippines. Of course, there were strict controls in the airports, and I was going through several fever or temperature checks. But other than that, there was not so much going on there. And until that time was already modeling something in Poland, and they had already, I think, middle of February, the whole model and the algorithm implemented to some certain extent. And then the next panel member, I'm very happy for, Professor Streit, was somehow saying I should call Till Krüger because there is something going on, and maybe I could also work a bit something out for Germany. And then MOCOS was somehow internationalized. So just to tell you what MOCOS means Modeling Corona Spread. It's an international research group of, right now we are in 4.5 countries. So we have MOCOS Poland, where everything was founded at the University of Wrocław. Here is Till Krüger, one of the founders, or the founder of MOCOS. And you see that there are a lot of people in the Polish MOCOS group, which comes from the fact that they have also a lot of people from different universities and also from companies like Nokia, which are assisting them and also helping them to get data and things like this. And right now they are consultants for the Polish government, especially for the health ministry, and have to do weekly reports about the status of COVID in Poland. And we're also very much involved in very strong decisions which have been done in Poland recently. There are a lot of people from different subjects, like computer science. Of course, we have people from medicine, from biomath. We have people here from epidemiology itself, and of course statisticians. Maybe to name two more than Till from the Polish group, it's Marcin Bodich and Tomasz Ujański, which were the developers of the code. And you can see some of their names throughout my talk at the sources. And I'm very happy that they are very, very generous in giving their nice plots. And always you can just call them, and in some hours they are actually directly giving you what you want. And this is so nice. So all of that, I'm actually this whole MOCOS group, I think we have a very good cooperation right now. And yeah, in the Philippines, MOCOS was founded in let's say the end of March, beginning of April. I was joining the group in Germany something like when I came back 1 week after I came back, as I told you, from Philippines. So we started then the first things to do for Berlin and for Germany, and then I was discussing with people in Philippines because I just came back, and I have also now 2 PhD students I'm supervising from MSU-IIT, and therefore I have a very intense contact at the moment. They're also watching right now. So hi Remy, hi Joy. And like this, MOCOS Philippines was founded. Leader is Jinky Bornales, who is also on the panel today, and the co-leader is Randy Kagaanan and Daisy Plastico. Also here it's very interesting to see that we have not just one discipline, but we have mathematics, we have computer science and statistics inside of this group. And this is very important also because you have to cope with a lot of difficulties on different levels. It's very good to have a very broad knowledge inside of this group. Yeah, last week, Asha Sherling, one of my PhD students in Germany, that's why she's on 2 groups. She's at the moment stranded in India, so in her home country. She went back to visit the family and couldn't come back because of the flight restrictions. And then she decided also to do something for her district or for her state. So she's in Kerala, and since last week the code is now also running in India. She's doing this together with her Professor Panda at the NIT in Kerala. If you want to see what we are currently doing, I can just recommend to you, if you want to see a Filipino version of the webpage, is MOCOS MSU-IIT edu.ph, where you can see how the Filipino group is last working, what they are doing right now, reports we recently wrote, and yeah, who is in the group and whatever. And the more international side, but also you can see a lot of the Polish results, is mocos.pl. But of course, there are also the reports from Germany, also partial from Philippines. So I just recommend to you this, and of course, if you want, you can just put MOCOS Philippines inside of Facebook, and you get to a nice Facebook group, and just make some commercials. And if you like it, then like it. Okay, so yeah, that's in principle our group. And now maybe what is the problems with COVID and diseases in special? Well, I checked yesterday ResearchGate, and we have now 46,000 preprints since January 2020 about COVID-19. This is a problem for most of the people, because you don't know really where to look. It's just a lot. Yeah, so you really have to keep up reading. You have to update your data. You have to discuss with a lot of different people which are specialists in this field. Also to read the major journals, what is happening in medicine, what is happening from the mathematical point of view. Are there new ideas and new features which you have to can put inside of the code? So it's just a vast of publications right now, and most of them are preprints, so they are not yet accepted. We know that if you publish something, it can lead up to some months that you get somehow accepted. And of course, with this amount of preprints, it's very hard to get a peer review of all of them. So the question is somehow how to deal with this. It's a problem itself, I would say. Then you have reliable data is inaccessible. So you have sometimes, especially, for example, in the beginning of the disease in Germany, we had this problem. The ministry, or let's say the Robert Koch Institute, was collecting the data, which is in Germany on a federal level, and you have some time lags. And for example, it's at the beginning, it was already something like there was data which has a delay of something like 14 days. So it could be that just at some day the outbreaks was much higher, or you had much more new infections. And to model with such things is very hard. The other thing is that we still, for example, don't know really what's happening with kids. So you can, for every opinion, you can find, I think, the same amount of papers if the kids are very infectious or not. There are completely different studies about attack rates in households, and things like this is very hard to find data. So there you have to somehow manage to do that. How we do it, we sometimes just model, or with our model, we just try to simulate both and check the core qualitative behavior. The parameters have to be updated quite often. Much of the disease is unknown, and the data are somehow misleading sometimes. So just look at this graphic down here. I hope you can see this hand. So the total cases of the Philippines. This is from Worldometers, and I took it yesterday night at 1 o'clock, so I think it's actual. So maybe it's 1 day more. So it's really like the last days. In the Philippines, you see this thing is a linear scale. It's not logarithmic. If you go to other countries, like for example, Germany, France, or whatever, you can see that at the beginning you will have an exponential growth. That means if you make a linear scale, you will see the typical behavior of an exponential function. Here you see a linear function and another linear function. And this can come, I don't know, but it's very, very likely that this comes from the fact that you are close to testing capacity. That means the number of new infections are constant. And then people think sometimes, and this one has to be very careful about that when you read in newspapers, the number of infected is this and this. It's not the number of infected, it's the number of confirmed cases. So this is the first thing you should understand if you read newspapers. And you see here that this is completely linear. That means every day you get the same amount of new infections. And then, of course, you increase the Philippines increase the testing capacity, and you see it's going on linearly. So it's very, very important to know what this means. This means here, in principle, just that more testing has to be done, and that these are really just the confirmed cases. So there could be much more outside. You see also on the right-hand side, that's something what Mocos Philippines did. So thanks to Joniel. I think this is 2 weeks old, so I apologize for that now. So what you see is the Philippines, of course. And you see yellow spots. These yellow spots are where the infected are from. And the blue dots are the testing centers. And you see that actually just around the testing centers, you have a lot of infected. And then if you go outside from these testing centers, there are not so many infected anymore. You have to be very careful with this. This can just mean that it's very hard to transport specimen to the testing centers right now. That means maybe there are no tests, for example, down there in Bislik and in the eastern part of Mindanao. So one has to be careful about this. And it's very, so I know that there are people wanting to say that it's very important to build more testing capacity where there are people infected. I would say it's maybe more interesting to also look at those regions which have not been tested yet and trying to test them massively to take a look if we have there also some spread. Because we just don't have information about these regions. And this makes it very hard, for example, in the Philippines to model stuff. So the lack of data is a big problem, and especially the lack of confirmed cases, so that you have the testing capacity is not so high. But it's still doable, and I will also talk what we are doing there. But that's how you should read your data when you or read the newspapers when you talk about infected people. I just want to talk a bit about modeling diseases. So Jomar Rubayante has this nice CIS biology group in Philippines in Facebook, and you can see different models like this. He's posting there constantly and also updating very nicely what's up to date. So thank him for this. So in principle, you can distinguish models which are differential equations, so compartmental models, SIR, usually, of course, so this I took from Zika, because it's just a nice picture, but in the COVID, you will have a SEIR, so you have also exposed, you have some asymptomatic cases. There are, if you just check ODE model for COVID in Google and just take Google images, you will see many different models, but which are all more or less from the structural point of view the same, in the sense that you have an ODE where you have different compartments, and the compartments are linked via rates, and so you can somehow build up then model which averages over these compartments. This is very good if you have a lot of cases and you don't have much heterogeneity. So if you are close to, if you are not at the beginning of a disease where you just have small amount of cases, these SIR models are good. And for example, in dengue, we still use them. Then there are spatial models, so where you can see that people are traveling and then they go into different cities, and it's more like you have different compartments going somewhere, or a different bunch of people going somewhere. You have meta-population models, which is a bit like the mixture of both. So you have an SIR model in every region, and you couple them via migration. There's also a model coming up by us and Randy soon for the Philippines. Then network models, which are more related to that what we are doing, and individual-based or agent-based models, which in principle is that what we are doing. So what is the advantage of that individual-based model or network models? If you talk about random graph models like that, what we are doing, you can deal better with heterogeneities inside of the population. That means you can really model something like how big households. That's what we are doing. You can model in principle, if you have data about it, you can model workplace contacts and things like that. And if you model this with ODEs, you get a huge ODE system, and this makes things usually very slow. The agent-based models are, of course, more costly in simulations. This is clear. So we cannot run a model in something like seconds or something, but we can do it quick enough. And of course, you have then to average. You have to do more runs because it's stochastics behind. But it's better for, let's say, to deal with heterogeneities, and especially at the beginning of a disease. This is from Mokos Poland. They have patient data, and they checked actually where the different people, the infections of the people are coming from. And you see down here this bottom line, the Muller plot here. This here is the household contacts, and you see that they play a major role, and they are more or less constant. Of course, there's an outbreak. There's here a bit more, but you have a constant level of household contacts. That's why households are somehow very important. The case or the fact why schools are not so important here is that the schools in Poland are actually closed. So you see here a small bubble of outbreak in schools, but then of course not much is happening. I think the kindergartens are open maybe now for 1 or 2 weeks or 3 weeks. I'm not sure, but also not so long. That's why we cannot expect here to see a lot from schools. Here, by the way, you see a major outbreak in a coal mine, I think, in Poland. So things like this you can see. But what's very striking here is that you have this constant household structure or household contacts, which are there and have to be somehow incorporated. And that's why we started to do that modeling. What we are doing, or we actually came to the model as it is now. So we have an agent-based model, and so if you don't know what this means or how the model looks like, just think about a random graph. So it's not Erdős-Rémy, and Till Krüger can talk about random graphs, I think, much longer than I can do. But if you want to have something in mind or some idea about what's happening is, let's think about you have a random graph. Every node is an infected, and then you have connections between the different infected, of course. And so this is a semi-realistic microsimulation model. And why is it semi-realistic? We have a specialist, Pablo Gorgat, who is very good in microcensus data analysis and also statistics for micropopulations. And he is actually using, for Germany and also for Poland, we do the same. He's taken the census data, also for Philippines, of course, you can get from the DHS report, Demographic Health Survey. And he is doing a sample population. And this sample population is then used as underlying population we use our model from. So we go to the we use for the whole simulation. That means what we do is we really try to sample, and we try to make a sample of the population of the entity that we are really looking at. That means if you have a city, we take the microcensus data, we take the age structure, we take the household structure of it, generate a random sample, and then we are simulating based on this. Moreover, we distinguish between inner household and outer household contacts. And this leads to a so-called outer reproduction number, R star, we call that. Don't mix this up with R0. It has to do with R0. But in principle, you can see it as a quantity which tells you about how many secondary infections outside the household you have. And why are we doing this? Because you cannot somehow efficiently do countermeasures against the infections inside of the household. Because people are living in the household, you are meeting everybody who is in the household somehow. And outside the household, you can say, okay, I do social distancing. So this R star is somehow the only free parameter, and I will talk about this in some seconds a bit more, of the model, which means that if you want to reduce the outer household contacts, we try to reduce the R star. Yeah. And that means the whole social distancing, everything which somehow is a countermeasure against the outer household contacts, this is somehow encoded in this parameter R star. So to say a bit more detailed, what we are doing, we have a non-Markovian stochastic process. We have the incubation time is log normal distributed. Here we have these parameters we have here are from our first preprint. They are from Lauer, which is from Annals of Internal Medicine, same as the age-dependent probabilities we got from WHO. Then we have a gamma distribution for the time till hospitalization. And the infection process is based on the contact structure, of course. That means you have to meet somebody, you have certain contacts, and then a certain infectivity. Right now, because we have polished patient data, we can use some of these parameters from our data itself. We have not started to do that yet, or maybe partially. But for example, for Germany and for Philippines, we haven't used this data yet. It's of course a bit problematic to use here Chinese data. So partially this data from China for a European model. So if you have something, you want to do something in Europe, the hospitalization in China is definitely different than in Germany. And then you would have somehow to maybe get better data there. But we have now, since we have patient data, or the Polish team has patient data, it's maybe good to use these parameters in future. But this is coming soon. Moreover, we have a click contact structure. That means we think that in the household you meet everybody who is in the household. It's very likely, so the contact con equal to 1. And then we have an infection probability, which we adapted a bit. So if you look at our preprint, you have 1 minus e to the power minus t over L, where L plus 1 is the household size. Here we put A, which is some sort of an attack rate, in a household attack rate, because it is now said from different publications that the household attack rate is a bit lower. So we use now 0.3, 0.007, and just check what happens. We can see later on how this influences the model, or what it doesn't influence also. But that's in principle how we model infection inside of the household. And then we have some certain time. So the time to stay at home with mild symptoms is gamma distributed. Outside the household, on average, we have 2.34 second times this. A certain constant we can put, which is somehow the free parameter of this R0, secondary infections per infected, and then you see that the number of secondary infections is Poisson distributed with C times T. So this C here is definitely vary if we want to vary the outer household contacts. That means if you want to reduce the number of infections, we try to reduce that. Okay, so this is the model, and now what's coming out, what we have done. So the first thing was the question, what is about social distancing and can we mitigate? Mitigation strategies are well known for flu, for example, and this means that you want to keep the disease at a certain level, which is still critical, but not so critical that it kills or threatens your health system. That means you want people to become more and more immune. So you wanna get a certain amount of herd immunity to prevent a second or third wave. That's the mitigation strategy, which is, for example, typically UK tried it at the start of the disease, and also Sweden, for example, was doing a herd immunity strategy at the beginning. So what we wanted to do is we want to benchmark where is our R star. R star is somehow something which we came up with. So we have to somehow get an idea what was before the lockdowns, because we have had, of course, lockdowns, and we cannot wait until the health ministry stop to do the lockdown. We have to do measurements and something like that. But what we did here is we just took the disease from 5th to 20th of March. This is, for example, for Berlin, and the red curve here is the actual number of infected people in Berlin. And then we checked which of our parameter values of R star is somehow the most likely to fit with this curve. And we have here, for example, a box plot, and you see that for Berlin we get this 3.883, and that's then what we assumed as the R star predicted before lockdown. For Poland, we had 3.16, for Germany 3.04, for Berlin 3.88. This comes from the fact that the household and age distribution in the different entities is, of course, different. For Wrocław, at that time, we didn't have enough infected, I think. Right now, we would also have a value, but I mean, I wanted to stick with the same values here. And for Iligan, also, we had no detected cases at that time. So also here we have nothing. So, and then we checked the mitigation interval, and how you can somehow say what is a good mitigation interval. Well, we said that R max this year is the smallest R star for which all of these random samples surpassed the ICU limit in a given time. That means you have a number of ICU beds. You can look this up, or you can ask people from medicine, local doctors and so on, and they can tell you the number of ICU beds. And you just check how small has to be your R star such that you threaten this ICU threat. That means that the number of severe cases is too much that the health system can cope with it. And R min is somehow this the largest value R star for such that you have less than 50% of the initial infected after 200 days, and you are not surpassing the ICU capacity. That means that you are in a suppression. Suppression means that the disease in the long run extincts. And then you see you have an interval here, which is very, very small. So if you compare this is 0.37, and we are in Poland before lockdown, we had 3.16. So the difference between this is 0.11, which is very small in comparison to that what we had before. So you have to see, if you meet here 10 people, this one would mean you meet one guy. And then you would have somehow that you tune this fine enough. You have to be between a bit less than 1 and 1 in average. And yeah, we said that this interval is much too small. So you cannot tell any state to say, okay, directly hit this interval. So you are in the middle of this interval to get herd immunity. We cannot tell anybody. And that's why we said that the mitigation strategy is likely to fail, because if this interval is too small, either you are in suppression or you threaten your ICU units. So, then the question is what to do against the disease. So then you see newspapers, testing is very important. And the question is a good testing strategy replacing social distancing? That is, you can ask. That means if you say that you find, like this assumption here, what we did is you took you find the number of mild cases after 2 days and all severe cases. That means those which are going to hospital and need somehow special treatment, you find definitely. And here down on the x-axis, you see the reduction per contacts, and this is the probability to find mild cases. Yeah. So if you find the mild cases, this you find them in maximum 2 days. So we get some heat map, and you see here. So this is in percentage of the full. So the prevalence in percentage of the population of the entity. This was Wrocław. You see here, nothing happens more or less. That means if I find somebody with probability 1, so 100% after 2 days, even if I have just a household rate from 0.07, I just need a contact reduction of about 40% to be in this section here. And then you see what we always see in every of these models, and it doesn't really matter if you talk about backtracking, if you talk about testing and something like this. This interval here, that means in the contact reduction, is very small, and this phase transition is incredibly steep. You go from a very low, so this is 1/100 of the complete entity to the full entity in just a small step. So this phase transition is very, very steep, and it doesn't matter how the household contact looks like. Here you have 0.3, you still see that it's very steep. It's getting, of course, steeper in that case. So this phase transition is very, very important, and it's very, very steep. So we have here a very small and a very thin region where we can actually try to do something like a herd immunity. Yeah. And you see still that even if you find a lot of people after 2 days, yeah, and 2 days is already something you have to work a lot for 2 days. Yeah, you would have to do really good testing, and especially if there is a weekend in between, people have to work and something like this. So 2 days is not always given. Yeah, yeah. But after 2 days, even if you find 100%. You still need some contact reduction. So it's not that testing is doing everything. What else can you do with this model? So this you can find also in the MOCOS PL page. So you can, for example, take the number of cases. So this is the 7 days average, and you can do a forecast. So after some certain time, you just say we let this thing run. So we take the most likely trajectories, and then you take some certain, you simulate the quantiles, and then you can say more or less what is likely, how is the prediction of the next days. Yeah. Also in Philippines, we would like to do this in future, but this we can, for example, do with our model. If somebody is more interested, just take a look at the MOCOS page. And then you can see where you are. That means it's very hard to say where are we now with the disease. So how much contact reduction we have in average, yeah. So what is the typical number, and how many people we are, for example, detecting. This is also not so clear. So what you can do is you can just take our model. You can just do this here, so you make a lot of runs and check where it's more likely to be, and then you check the likelihood of the cells you are in, so to get the proper combinations, which are the more likely combinations of detection and contact reduction you have, and then you can plot them here, and you can see where you are. This is, for example, then for Poland. Okay, so now this is from MOCOS Philippines. This was from Cagayandoro. So we did the household structure for Cagayandoro, and we started with 10 cases at the beginning, and then what they did is they changed now the time interval. So before I said after 2 days we find the mild cases. What happens after 7 days? What happens after 14 days? And there you see that this changes dramatically. So while here, you have somehow on the diagonal more or less good values, and then you have the prevalence up here. That means if you have a detection rate of 0 and no contact reduction, of course, it should be terrible. And the more you detect, the better it is, and so on. But after 7 days, already, just if you find 100% and you have a contact reduction to 20%, that means if you meet before 10 people, you meet just 2, then you are in a more or less safe side, and otherwise you get really in trouble. And if you know that the disease is lasting 14 days, this last picture is actually not very surprising. So of course you need a lot of detection, and 0 for your so you have to go to 0 other household contacts almost. So what is crucial here, what we see directly is we need very quick tests. So the tests should be analyzed quickly. It's not every time lag we have is making a trouble. So what we started recently, or something like 1 month ago, is backtracking. So you can now run because you have a random graph, you can run the infection back on the graph. So you can just check how likely is it to find the infections 1 step, 2 steps back in the random graph. And of course, for this, the information of context has to be available. So if you want to do this in real life, of course, backtracking needs a lot of people to do the backtracking. With the app, this can speed up the process. And it's not that I want to say something against this app, but we can just take a look at this here. We have here the backtracking rate, and we have here the contact reduction, and we have here the detection rate of mild cases. So 0, 0.15, 0.3, 0.5. Of course, the more classical detection rate of testing I have, the better is the picture. So the less red area I have. But you see also that the backtracking has to have a quite high rate, that something happens. You have here almost a vertical line up to a backtracking rate of 0.4. Here also, so you need something like 20% of backtracking rate if you have a very high detection rate of the mild cases, 0.5%. So of course it brings something. So it's not that you should not use the app at all, but the more people are using this app, that's you see here, and in combination with a high detection rate, the more it brings. So it's very important that you have a lot of people have this app, and 60% is somehow that what the Oxford study said should be there. But this is somehow similar to that what we see here. If you compare that with this in this picture, of course it's getting a bit better. With the contact rate here, and this is the 60%. You just need, the more people are using this app, the better it is. Importance of the delay. So if you have tracking delay of 1 day, 2 days, 3 days, 4 days, you see that it's getting more and more worse. So 1 day, this year you see that if you have a contact tracking with effectiveness of 100%, you have already here, when you go to 30% of contact reduction, that means you meet 7 people instead of 10, then you are already at the threshold that you meet the high case numbers here. At the moment, it's like, so most of the tracking apps have a delay of 1 day. It's also the German one, in order to somehow prevent that you stand in front of somebody and the app is telling you this guy has corona, and then you somehow do something to him. So this delay is somehow needed for data security reasons. But on the other side, it's of course a small problem. So what the Polish group did is they just took half a day, and then you see already that it's much better. So you see that this really brings something. So the difference between half a day delay and 1 day is already given. And moreover, if you now say that you find 15% of all cases, you you see that in combination with this, you can almost let 100%. So you are here in a quite good region already. Of course, if you impose more contact reduction, the better it is again. But you see that a quick backtracking with a efficient testing or extended testing in combination with contact reduction, which is a bit like contact reduction, is making somehow the measures much more effective. Okay, so now the last point. I was checking school openings for Germany. So we had in Germany at the beginning of April the discussion if the schools are opened. And what we did is we did a scenario where we just opened the schools, which means for certain age groups, we increased the contact number. What we haven't modeled yet is the hygienic measures in schools. We should go there a bit more precisely to do that, especially something like how a classroom should look like, so how far they should be out away from each other. For example, are they wearing masks? What is with breaks in schools and things like that? So these are things which have not modeled here yet. It's just that we increase the number of contacts in different age groups, and different parameters have now changed because of course, aerosol infections were at that time not such a big topic, and moreover then the masks. And what the masks are bringing is not yet inside of this model. Yeah, but anyway, so what we could see is that if the contact reduction outside of the school is also high, then also and then you can somehow with a small contact reduction inside the school also open schools with a mild danger, let's say. Opening schools always brings a danger because you have some contacts, some outside of the households, which can go again back to the household. So and it's always a problem when you somehow couple a lot of households with each other. It doesn't matter how you do that. So if you go from 0 to a bit, there is of course then a problem, and that's what you also can see in the school openings. So we did this for Berlin, and this is, for example, the corresponding table. So you see, without school opening, we have a prevalence after 300 days of 5,000 that time, which is median. And if you open this for 17, 18, 16, 18, and 15, 18, you see that it just, if you have a small contact rate in schools, which is 18% of the contacts before the lockdown, and then you see that just a small amount of people is getting more infected. Here you see the immunization. That means we could do it for 0.5, 1, 4, and 8 immunization, and the reduction, contact reduction outside is 90%. So we have 9% of the people from before you meet outside the school. Yeah? So that means you have a strong lockdown in the population. So now, of course, if somebody looks at this table, they think, look here, 18%. You have just a small amount of the. So even from 16 to 18, the numbers are less. I know. This is stochastics. So there are not so much runs we did here. So many runs, and it's also median, and it's what you can see from that is actually that it's really at some certain small threshold. So there is not much difference here. Moreover, if you think about kids, usually if you have one kid in 17 in the households here, we had also a lot of siblings. That means there's probability is quite high that you have also a 16 or 15-year-old inside. That means a lot of infections, which maybe you have done in school, could be in the other case done in the household. Yeah. Why we did here the 17, 18, and 15, 18-year-old? Yeah, because there is a strong discussion going on about how infective kids are. And the 17, 18-year-old, 16, 18-year-old, our idea was that we could treat this like an adult. So that's why we did it with these age classes. But what you see again is if the contact reduction outside of the school is high, that means if you have a lockdown, then you also can open the school with mild contacts. Okay, now come to my end. So what you should learn from this talk today. So the phase transition is very small. It's so small that it cannot be tuned fine enough to get herd immunity. And it doesn't matter if you do backtracking. It doesn't matter if you do testing. This phase transition is always very, very steep. Of course, not the phase transition is small. The phase transition is big, but the interval is very small. The households seem to play a crucial role in the spread because they somehow can be used as a buffer. You have some micro epidemics through the households. Testing has to be combined with social distancing, and of course, the backtracking would be perfect. Parameters are still a problem, and backtracking is effective, but it should be combined with the other measures. Currently, we are working on the influence of super spreaders. There we started to work a bit to take a look what happens if you somehow cut massive events or a massive gathering of people, and where you should cut this. Then you have the estimation of the dark figure. This is a paper which is coming out this week, should be coming out this week, which is based on Polish patient data and has also some new insights because there is data there. And the model for tracking app and more detailed discussions of the school opens will be done in the future. So this is still to be worked out. And of course, for the Philippines now, we are working especially on regional models. So to combine the different islands with each other, this is now coming. And moreover, to take also a look here on things like supermortality and stuff like that. So thank you for your attention. I hope you enjoyed it a bit. If you have any questions, then please feel free. And I think questions I should put this slide for the questions and answers.
Thank you, Dr. Ball, for your illuminating discussion. First of all, I would like to apologize for the technical difficulties, but thank you for staying with us. Now, let me acknowledge the presence of Dr. Till Kruger, the MOCUS founder, also Dr. Bornales, the team leader of MOCUS Philippines, Dr. Mylene Uy, the director of PRISM, Dr. Efraim Tilio, the dean of the College of Science and Mathematics, and Dr. Daisy Lupolistico and Dr. Randy Cagaanan, the co-team leaders of MOCUS Philippines. Now we are ready for the questions and answer session, and we have a special guest here today who has the privilege to raise the first question live. He is from the Bielefeld University, Germany, and has frequently visited us here in our university as a visiting professor. Let us welcome Dr. Ludwig Streit. Dr. Streit, you may now proceed with your question.
Well, thanks first of all to, as I may say, my colleagues at IIT for setting this up, and more importantly for setting up the research team that has been so productive. To the speaker, frankly speaking, I didn't have a question because this was very clear and left for me no questions open. However, what concerns me a lot is this dramatic lack of testing in the Philippines, which makes life so complicated for the modelers, but also causes enormous concerns for policy measures. In this, Wolfgang Bock showed a graph on the linear increase step by step of infection rates. There's another one on the same source where somewhere toward the end of May, the number of infections in the country suddenly doubled. you wonder what happened. Infections, basically from one day to the other, suddenly doubled. That wasn't the case, only there was the double amount of testing, meaning that the testing doesn't really see what's going on in the country. It just sees what happens in those few localized testing centers, and you do not have a picture of what's actually going on. To make it more clear and simple, you know, the guy who has a huge orchard and with mangoes, and he wants to create a business plan for selling mangoes. So he has a basket and a kid. He sends the kid out with the basket. The kid comes back with 10 mangoes, and the farmer says, "Oh, I have to plan for selling my fruit. I have 10 mangoes. What is my business model if I have 10 mangoes?" The trouble is he has only one basket. And this is what's happening with the testing. There is no realistic picture. And I think it would be good to look at two remedies in terms of this dramatic lack of information, which is jeopardizing the whole policy of containing the disease. The first one is to get at least a global idea of what is lacking in terms of information by looking at what other people have been doing in other countries, is to look at the excess mortality. That doesn't give you a localized idea of where exactly, which barangay you might have a problem, but at least city by city you see what most probably is going on beyond the usual deaths that you encounter. For that, you don't need testing. You just need to look at the registry of deaths and burials, and I assume that is available in the Philippines. The other thing that I'm wondering about, what about mobile testing units? I mean, you're testing in Manila for obvious reasons, in Davao, and a few other spots, and there we have the disease. What in the other places? In other countries where you don't have the funds to cover the country with testing, with fixed testing stations, people use mobile units. Why not implement those in the Philippines? That is a question I don't have to the speaker, but I have to all the people that are inside this discussion in your country. Thank you very much.
Maybe I can add a question here or a comment to what Ludwig said and what also relates to the presentation of Wolfgang. Can you hear me? I hope so, right?
Yes, sir. Yes, sir.
Okay. Yeah, indeed. It's really very true that increasing testing capacities is a crucial thing. And there is a misconception, sometimes also present among officials in several countries, that if you increase the testing capacity, your numbers will go up and the picture will worsen. I mean, and you should avoid this. And I think in some countries like Belarus, you have a little bit of this strategy. So governments are sometimes afraid to increase testing because they think, I mean, the picture will look bad. And indeed, you uncover more cases, that's true. But you should not forget that as more cases you uncover, as more you can slow down the epidemics, because you then can put the people under quarantine and avoid further contacts of those detected cases. So increasing the testing will at first increase the observed and detected cases, but then you can really bring the epidemics below criticality line and make it subcritical. So in Poland, what for instance happened at the beginning, we had the probability by testing finding mild cases was about 10%. And it increased over the last months to now something 60%. And that's more or less allowed the country to open or to release the contact restrictions to almost a level how it was before the epidemics. There are still certain activities are still forbidden and people have to wear a mask, which is certainly contributing to a certain social restriction. But the social restriction is very moderate, and you could achieve for these moderate restrictions just by increasing the testing capacity to a level that you really find enough cases and detect them. That means essentially from a practical point of view, you have to have fast working labs and you have to make tests easy accessible. So if a person has somehow mild symptoms and consults a doctor, the doctor should not hesitate to make a test looking at the price or something. It should be easy and quick. And then you really have a very good weapon against fighting the epidemics and really controlling it. And Wolfgang has shown this in a very nice picture in his talk. And so I just wanted to support or to somehow strengthen a little bit what Ludwig already said. It's a crucial weapon in the fight against the epidemics that you have yet to test enough people which are just a little bit suspicious for testing. There is, of course, something which can a little bit replace the testing. And I think for the German situation, it was actually observed. So if you encourage people which have somehow mild symptoms to stay home together actually with their family, that would have the similar effect, right? You don't go out, you stay home, and you just call your doctor, and the doctor say, well, I give you a license to stay 2 weeks, say, at home, and you don't have to go to work. In Germany, this was done formally in the way that you could just call up your local doctor, your physician, and it said, I have a little bit cough and a little bit fever. And he said, well, stay home, you get full payment for 2 weeks from the normal health insurance. And in Germany, within the last few months, 1.5 million people have declared to be sick, which was an unusual high number, much higher also than the number of observed cases. So my conjecture is that a good part of those people were probably sick without having anything related to coronavirus, and they just used the opportunity to stay home. But still, you catch those to a large part who really were infected with corona, but had only very mild symptoms, so didn't feel really need to go to the hospital or to have an intense care unit treatment. And this helped a lot. Now, this, of course, depends on economical power of the country, if you can afford paying the people off for 2 weeks. But it's certainly an additional thing which comes. So you should suggest people not to be afraid to be tested. There should be no stigmatization of people who have been uncovered. And it's a very crucial point here, which Ludwig made, that this is a problem in the Philippines.
Yes, sir. That's right, sir. Thanks for your comment. We would like to hear from Dr. Jimmy Bornales, our team leader. Dr. Bornales, would you like to say something? Anyway, at this point, we would like to thank Dr. Strike and Dr. Kruger for being with us. We will now go to the questions of the participants. First question. From Jaya Kingson. Good afternoon, sir. How significant is this model, and what are some of the influential factors that may contribute to this model?
I mean, the significance of every model somehow has to be fit to reality somehow, and of course, it is especially about what we know from the disease and what we learn every 2 to 3 days. It's very hard to say, okay, if I get something like 1,002 people out, that it's exactly 1,002 people. So what you can just see is the significance of this phase transition is something that you can see for all parameter sets we have tested. And the household structure seems to be one of the core ingredients here. And you should really have the household structure inside of these models. And this really brings also a difference. So there is a significant difference if you take a usually SEIR model and our model in the prevalence. You can see that with the households, it's much steeper, what we have. And that's what we also saw in the first days of the disease in some countries.
I was also impressed with the emphasis on a fast reaction, which makes all the difference in controlling the spread. It's really crucial that things have to happen on political reactions to an outbreak have to happen on a day-to-day basis and without any delay. And that contains a message. In Germany, unfortunately, there was a phase where the political decision-making, the reaction to outbreaks was handed down to the regions. We have a federal system. And from the regions, it was handed down to the counties even, which are very much under political pressure to not act very fast. Lockdown, let's wait, let's see. And this is deadly. So the message is the monitoring should happen in the region, locally. And the decision-making, which is the painful and the hard part, should be put into the central government, where they are not so much victims of local pressure groups. I think this is crucially important. We now have a super spreader right next to my hometown, and we see how terribly painful the foot dragging of the regional authorities is. So monitor regionally and let the central government take the blame, one must say, to impose the necessary restrictions. This is an important thing that was unfortunately missed out in Germany, and now we pay a heavy price for it.
Okay. Next question. For our next question, we have here the question, what is backtracking and how is it related to contact tracing?
Okay, so you have actually two things let's say two major classes of testing. The typical testing is somebody has symptoms. Then you get this, what you have maybe seen already in Winter News or something. You get this long sticks inside of your nose and in your mouth, and they take some specimen and send it to our usually RT-PCR machine. That's the normal case of testing, and the backtracking is just that you somehow track back where the infection came from. That means you try to really track back all this infection chain as far as possible. And now come, for example, to this tracing app. In Germany, it's like this. You have your Bluetooth on, and another guy has the Bluetooth on. And if you are close to each other for a certain amount of time, the ID number somehow, there's a random ID number, is interchanged. If now one in this chain is positively tested on corona, he can voluntarily put this inside of this app. And then immediately everyone he had contact with for a certain amount of time gets warned there is a possible corona infection. That means you had contact with somebody who had corona in some certain amount of days. This means that you can go to your local health office and they make a test. And by this, you track back the infection chain. Yeah. Right now, it's of course done like this. There are sitting some ladies and boys and gentlemen in an office and phoning back. Did you have contact with this guy? Did you have contact with this guy? of course, in the household, it's clear. Yeah? If you're somebody in a household, you ask all the household members. But where's the contact coming from? So, are they more infected because of this particular guy, or where's the source coming from? This is called backtracking. So you track back the disease.
Maybe I can add still a comment to what. Can I still add a comment to what Wolfgang said? Indeed, I mean, contact tracing and backtracking are somehow you have to think them together, right? So when you find a patient, you uncover a patient. Now you try to find out the people he infected and also the source of his infection. The source part finding is the back part, and to finding the people he infected is the forward part. And a priori, we have in the model two different probabilities to detecting the back case and the forward cases. The infected person infected, so his secondary cases. And it turns out for Poland, actually, on the patient data, that these probabilities are essentially the same in our case. Now, it's important to have in this, when you do the contact tracing, you really try also to find the source.
Well,
so I had a conversation a week ago with a professional tracker in Belgium. And he told me that in Belgium, you only look for contacts which happened at most 2 days from the time point on when you find the person, or when the person's onset of symptoms was. That means essentially you never find the source of the case. So this is very, very much limiting or reducing the efficiency of backtracking if you only go forward. Both parts are important. It's not just the backtracking part important, or the forward part is equally important. But you should do both. And I don't know how it's organized in the Philippines. Who is actually doing this, whether these are voluntary people or whether these are professional people, say from the police, how it's done in Singapore. This would be interesting to know, and also the protocols they follow. So how they ask the person they uncovered about their contacts, and how long back in time they really try to trace. So this is maybe just an additional comment to what Wolfgang already said.
Thank you, sir. Another question here is, have the results of the study been adopted by governments with regards to public health policies on the coronavirus?
So I will say something about the Philippines, about Germany, and for the other question about government, especially Poland, I would maybe pass over to Till, because he is really directly in the process with this. So for Germany, it is now, I'm on a regional level talking to what you would say LGU in Kaiserslautern. That's the city where I come from. And we did some small model there. But right now, the situation in Germany is a bit more like easing lockdown and so on. And as Professor Streit said, it's on a very regional level. So we could not really see that it's going too much inside of the decision process yet. Yeah. In the Philippines, it was the extension of the ECQ was based partially on our model, I guess, in Iligan. So we were doing the simulations there, and we also said that the quarantine should be somehow extended. So this was something where we directly influenced maybe the local governments. But for the rest, of course, I hope that it's still to come. I mean, Poland is much further. So in Poland, our model is actually used quite a lot. So, but maybe Till can say something about this.
Right. So we are here since, I would say, maybe end of March, something like that. The government has created a so-called expert team from which they take recommendations. So we have written essentially weekly a report. We are not the only group. There are three groups in Poland which do reporting. There's one more group which do microsimulations and another group which is doing ODE models. But we are actually the only group which have all this countermeasure simulations taken into account. So the contact tracing, which is somehow algorithmically a little bit difficult, not the easy parts in programming. So I think you never know really how much of your recommendations the government finally have made use in their decision making. I think the strong increase in improving the testing, the easiness to get tested and the testing capacities certainly was in part to our reports. There is a different governmental involvement where I'm right now active in. This is with respect to the contact tracing app, the smartphone app. This is not done by the health ministry, but by a different ministry for this kind of technical equipment. And here we directly on direct contact also with the minister to recommend where the app eventually should be improved and what are the bottlenecks, which is mainly the usage frequency here, but also some intrinsically built time lags in this Apple Google app, which is on which the Polish app is also built. And so you can be influential. It's always, I mean, governmental administration is always a little bit a labyrinth. And within the administration itself, on the very high level, what we also have here, and this I think is not just a Polish problem, there is sometimes a little bit a poker game going on between different rivaling groups, and they use the report of one group against the report of the other group, and you never really are sure how the decision-making flow is actually in detail, how the outcome was really going on. But I think we are as close as you can be as scientists for the decision-making process here in Poland, and if things will worsen or would worsen here, then certainly our group would be one of the prime advisors. We would be asked what to do here in this special situation if you have again a worsening of the situation. So it's important to try to get heard by the officials. Yeah.
Thank you, sir. Another question would be, would it be possible for us to consider including the factors of time frame since people are actually moving?
Yes. So right now, I know that there is this, especially in Philippines, things like migration. I think that's what questioner was talking about. So you have some really regional movements where people go back to the cities for a longer time. During the COVID crisis, we are at the moment building a model with this, a very easy ODE model, and with Till we are already discussing for some certain amount of time to put also some regional models with the big agent-based model where we can incorporate such things. It's still in the trial phase, so we have a small ODE model for this already running in Germany right now. So one of my PhD students, or former PhD student, she is already postdoc right now. She was running these things for regional a regional level in Germany. And the next thing would be to check then also how this would be, for example, effective in the Philippines. It's not the Marcos model directly, it's an ODE model, but in the next step, the Marcos model could also be adapted geographically. We are talking about this for quite a while already, but there we have to somehow be sure about the migration and also about the movement of people. And the most problem here is data, because you are in a current lockdown right now. There are a lot of people in home office. You have flights between the islands. You have also ferries between the islands, but they are also not very well documented. I mean, flights are okay because somebody has, so it's clear that the area that the space over Philippines, this is somehow known what's going up there, so you can somewhat detect the planes. But ferries is a different thing, and also the movements on the big islands. Like if somebody is moving from Davao now to I don't know, to Iligan or to Cagayan or something like this, you really don't know right now. So and these things, you have to come up with different models for that. So these mobility models is also something I did when I was doing it with dengue. You also have a similar question in mixing strains in dengue. So we have some background and some experience there, and this is definitely something that should be up the next time.
For the last question we have here, can you please expound how the infection process is represented through random graphs?
Okay, so in principle, you can just say the graph is somehow built like you have somebody who is infecting the susceptible. So you have in principle what's there is a SIR model. Yeah, so you have susceptible in the population, so the susceptible agent, you have infected agents, of course, and you have recovered agents and dead agents. Yeah, and now you just let them meet. That means you roll a dice and roll a die, like we did this now, a Poisson distribution. So you some of them are meeting, and then you have a probability that they get infected, and then they build up this graph. Every node of this graph is infected. And yeah, but at the end, you get in principle a whole random graph of the whole infection chains. If you want, you can of course say much more about it, but you can give lectures about that also.
Yeah. Maybe I just add a word here on this topic. So what we define as the infection graph is a little bit a theoretical construct, and what we create in the simulation is a so-called forward connected component or a part of this infection graph. So the infection graph would be defined as in the following way: for each person, you make directed links to those person he would eventually infect under the assumption that none of his contacts would be a priori infected. And the probability that you infect, so a person I infect a person J, depends on the feature vectors and the time being infectious. And this is still separate for in and out household contacts. And that you can think of drawing a graph where you make for each person a link which represents the case if this person would be infected, which secondary persons he would infect. And then when you start now with a given subset of initially infected, you generate in the computer only the forward connected component in this graph. And for that, that is what the computer simulation does. But this forward connected component actually, at least to a good extent, you have even theoretical access. There are quite an elaborated theory on that. But the theory is really quite complex. So a long time ago, not directly related to coronavirus, but the underlying theory, I gave half a semester course at the Max Planck Institute in Leipzig, something like 10 years ago. So it's not such an easy thing to present in a nutshell.
Okay. Thank you. Now I would like to congratulate Dr. Wolfgang Bock, because we have here the slide poll statement. We have 100% strongly agree that the webinar is very useful. So yes, I think that is all that we have for this time. We will look for follow-up on our Facebook page, MOCOS Philippines or MSU-IIT PRISM. please take a moment to fill out our post-evaluation, which will be sent to you by email. And so, in behalf of Dr. Wolfgang Bock, as well as Dr. Daisy Lu Polistico and the Applied Mathematics and Statistics Group, and the Director of PRISM, Dr. Mylene Uy, we all thank you for joining us and taking the time to view our presentation. My name is Ruth Serkinia. Have a great day.
Thank you very much.
It was very nice.
Thanks to all of you.
Thanks.
Thank you also.